Dr. Dayananda Babu next. Professor Emeritus, Department of General Surgery, Sri Gokulam Medical College and Research Foundation, Thiruvananthapuram. Once again, we apologize on behalf of the organizers. We are running short of time. We are late by 45 minutes. Hence, there will be no discussions after the presentations. Thank you.
Esteemed chairpersons, fellow delegates, dear students, the topic allotted for me is Adrenal Incidentalomas, Concepts in Evaluation and Management. This was allotted to me by Debin, and I don't know, I readily agreed because during my endocrine surgery days, I used to talk on this topic. I bring greetings from Sri Gokulam Medical College and Research Foundation. Coming to the definition, an asymptomatic adrenal mass detected on imaging, not performed for a suspected adrenal disease, is termed incidentaloma. They can be functioning or non-functioning. They can be benign or malignant. Approximately 3% of the population will have unsuspected adrenal mass in abdominal CT for an unrelated problem. And by the age of 50, 10% will have incidentaloma, especially in the elderly. All solid masses of the adrenal should undergo biochemical assessment. Selective screening is required on the basis of clinical and family history. MRI and sometimes maybe MIBG may be required. This is a 1.5 centimeter incidentaloma which is non-functioning. The arrow is pointing. Now, coming to the differential diagnosis of incidentaloma, maybe adrenal adenoma, majority adrenal adenoma, then pheochromocytoma, myelolipoma, adrenal cyst, hematoma, ACC, the adrenal cortical carcinoma, and adrenal metastasis. This is the approximate proportion. 60% are by non-functioning adenomas. Maybe 10% will be formed by pheochromocytoma, then 5% cortisol producing, that is a functioning adenoma, aldosteronoma, maybe only 1%, that is the least. And then adrenal cortical carcinoma 5%, adrenal cyst 5%, ganglioneuroma 5%, and myelolipoma again form about 9%. In cancer patients, 75% would turn out to be metastasis. So if there is a history of carcinoma, then you get a mass in the adrenal, one should suspect metastasis. 65% would be benign adenoma without history of malignancy. The prevalence of adrenal cortical cancer is directly related to the size. Between 4 and 6 centimeter size, the probability of the adrenal cortical cancer is only 2%. But the size, if it is going beyond 6 centimeter, the percentage reaches up to 25%. 70% of the masses are non-functioning, and maybe more than 10% turn out to be pheochromocytoma. So how will you evaluate? Most important is a clinical detailed history, physical examination, the symptoms and signs of adrenal hypersecretion like Cushing, pheo, or maybe the primary aldosteronism, etc. And history of extra-adrenal cancer for the patient also is important. First question is the tumor functionally active or not? You have to do certain biochemical tests. The overnight dexamethasone suppression test, 1 milligram. If serum cortisol is more than 5 microgram in the morning cortisol, then the test is considered positive for Cushing, and along with that, the ACTH will be non-detectable. A fractionated urinary and plasma-free metanephrines, if it is greater than 4 times the upper limit, one should suspect pheochromocytoma. Aldosterone-renin ratio, which is called ARR, more than 30 or the diagnosis of an aldosterone producing adenoma, and maybe plasma aldosterone concentration more than 0.5 nanomole also may be very valid. The serum potassium, again for hypokalemia and sometimes sex hormones must be done. Most important radiological investigation is a non-contrast CT and measurement of the density by Hounsfield unit. The non-contrast will decide the size of the mass, the lipid content of the mass. The Hounsfield unit is decided by the fat content, and there should be at least 30% enough fat for this. If the fat content is less than that, then may be wrong. So if the Hounsfield unit is less than 10, it will be a benign adenoma. Rapidity of washout is another thing. So look for washout. If there is more than 50% washout, then within 10 minutes it will be adenoma. And the radiological features of adrenal cortical cancer are diameter more than 4 centimeter, more than 10 Hounsfield unit density, contrast enhanced washout, maybe absolute value of less than 60, heterogeneous appearance, border irregularity, necrosis, lymph node, metastasis are suggestive of adrenal cortical cancer. A delayed contrast enhanced CT image 1 hour after injection will show all these things clearly. The adrenal cortical cancer, maybe if you are not sure, you can do MRI with a chemical shift. Carcinomas do not change in signal intensity between the in-phase and out-of-phase imaging, whereas in adenoma there will be a signal drop. MRI is superior to CT in detecting tumor extension into the IVC. FDG PET can differentiate benign and malignant because in malignancy there will be uptake and you can detect metastasis also. The MRI always the T2 weighted and then you check the adrenal mass liver ratio. If you get low signal intensity, it is adenoma. Intermediate intensity metastasis or maybe FCC, and bright image is suggestive of pheochromocytoma. This is how it will look in the CT of a pheochromocytoma, the central areas you have got necrosis. The moment you take MRI, it will become hyper intense like this, sometimes called the so-called light bulb sign. Now the cystic lesions again forms a differential diagnosis. It may be due to the reasons given below, the endothelial lymphangioma, pseudocyst, echinococcal, and true epithelial cyst. I have written sono-guided FNAC. FNAC is not usually done in adrenal because you cannot differentiate carcinoma from adenoma. So FNAC is generally not recommended. It is recommended only if you suspect a metastasis. So that is the thing. And myelolipoma again forms about 10%, non-functioning benign tumor from hematopoietic and fatty elements. Sometimes they may have pain. Usually they are less than 5 centimeter in size. They are rarely calcified. The CT will show gross fat. That means minus 30 to minus 200 Hounsfield unit. Hormonal assays are done to find out coexisting adenomas or carcinomas. And this is a typical appearance of a myelolipoma. Note the fat density in the CT. And coming to metastasis, 25% of the carcinomas eventually develop adrenal metastasis. And 50% of these are bilateral. Resection of isolated metastasis may improve survival. And carefully rule out extraadrenal metastasis in the liver, lung, bone by CT, MRI or PET. So if it is isolated in the adrenal, unilateral, maybe it is worthwhile removing. Complete adrenal metastatectomy can be done by lab. So what is required is a mutually constructive discussion between endocrinologist, cardiologist, anesthesiologist and surgeon rather than a struggle for supremacy in a contest of wills. So the management is discussed in the multidisciplinary team. A small, less than 4 centimeter benign, non-functioning tumors do not require surgery. Follow-up CT and MRI usually done at 6 months, maybe 12 months and 24 months. No consensus about further follow-up. Tumors more than 3 centimeter has increased risk of hyperfunction over the time. Indications for adrenalectomy are unilateral functioning tumors, imaging features suggestive of malignancy, tumors showing growth, tumors more than 4 centimeter size. Laparoscopic adrenalectomy is nowadays the gold standard. Unilateral adrenal tumors less than 6 centimeters without evidence of local invasion, lap adrenalectomy can be done. And also for small few. And the approach lap may be retroperitoneal or transperitoneal. So this is an evidence-based algorithm by the European Society of Endocrinology. Unilateral adrenal mass, radiological suspicion of malignancy. If there is no suspicion of malignancy, then you check whether it is a functioning tumor or not. If it is not functioning, then no need for surgery. If it is functioning, is laparoscopic adrenalectomy. And if it is radiological suspicion of malignancy is there, local invasion is there or not. If there is no local invasion and if the diameter is less than 6 centimeter, go for lap. If there is local invasion is there, go for adrenalectomy. And to sum up, they can be functioning or non-functioning, benign or malignant. 65% would be benign adenomas. Non-contrast CT and measurement of the density by Hounsfield unit. And if it is less than 10, it is benign adenoma. Contrast CT with measurement of washout is another most important investigation. FDG PET positive uptake will suggest malignancy. Discovery of an incidentaloma is not an indication as such for surgery. Indication for surgery are functioning tumors, malignancy, more than 4 centimeter size, and those showing growth. Thank you very much.
Thank you very much, sir. We'll be moving immediately to the next presenter. Thank you, Dayananda Babu, sir.
Okay. Thank you, sir, for this nice presentation. And sir has very clearly pointed out how to differentiate the benign and malignant incidentalomas by the various imaging techniques. Any questions from the floor?
Ma'am, we'll be moving on because